session of our seminar before David. And I know that is the most difficult moment because physiologically we are in the prevalence of vagotone. That means that we would like to sleep instead of to stay focused. So I will be your homeostatic agent in order to counteract the vagotone, giving my sympathetic tone, and we will recover a good homeostasis. Okay, good. We finish the first part of the seminar speaking about the relationships between the immune cells, and I suggest you, in order to have clear how they work to imagine them and imagine the immune system like a balance, where every plate of the scale is a TH subset. Especially TH are so important, as you know, because they are something like director of orchestra in the immune system. I want to make even more simple, and instead of to speak about TH1, TH2, Treg, TH17, I just speak in this moment, by a scholastic point of view, in terms of TH1 and TH2. Just to warm up us again, TH1, cell-mediated immune response, TH2, humoral immune response, but if upregulated, inflammation, atopy or allergic diseases. Now we have to jump to another level because we need to speak and think in terms of cytokines, specific cytokines, produced mainly by the TH1 and TH2. And they are, and we will speak not about all of them, but just the most important. Now, what is important for me is to find with you a consensus that is clear that TH1 produce immunostimulating cytokines, red ones. They are immunostimulating, I mean they are good when they are produced in the homeostatic concentration. The most important one are interleukin 1, interleukin 6, TNF-alpha, interleukin 17, gamma interferon. TH2 produce many cytokines, and they have an immunomodulating activity. That's the reason why I color them in blue. And they are TGF-beta 4 and 10. This is what happens if they are produced in the physiological concentration. But if one of the plates is overexpressed, from physiology we pass to pathology. For instance, if TH2 and Treg are overexpressed, instead of to exert their immunomodulating activity, they become cause of immunodeficiency because they work too much modulating the immune system. That means they push too much down the immune system. On the other side, if TH1 and TH17, if the inflammatory disease is an autoimmune disease, are overexpressed, they are the markers of inflammatory diseases. Every inflammatory diseases, and please remember, if we have the involvement of TH17, Crohn's disease, psoriasis, vitiligo, rheumatoid arthritis. This is really the best way to understand the immune system balance. Since we are going to focus especially our attention of inflammation, this is the scale that you can observe in your patient with inflammatory diseases. TH1 and TH17 upregulated, and they produce an excess, I mean in comparison with the homeostasis, of interleukin 1, 6, TNF alpha. You will see in a couple of minutes that every one of these yellow marked cytokines are involved in different moments of the inflammatory process, in acute, in chronic, and so on. And why they are overexpressed? Because that patient has an insufficiency in the Th2 and Treg subsets, or the quantity of pro-inflammatory cytokines is so high, it is a storm of pro-inflammatory cytokines that the homeostatic quantity of anti-inflammatory cytokines is not sufficient to counteract them. On the opposite, this is the picture of your patients, kids, with recurrent respiratory infections. Those kids that between September and April have 6, 7 tonsillitis. Why? Because the immunomodulating cytokines are so much that they are become immunosuppressing cytokines. So the immune system is not more efficient to counteract the Streptococcus beta hemolytic. Those kids have a lack in the immunostimulating cytokines. Please remember that always you have something up and something down. So, to wrap up what I am insisting on, in healthy conditions, both the immunostimulating and the immunomodulating cytokines are expressed in a homeostatic physiological concentration, which is the picture of a healthy immune system. If a virus attacks me, or a trauma, this concentration disappears, and a new picture of cytokines is in our body. Immunostimulating cytokines now are up, and immunomodulating ones are down. On the opposite, when we have recurrent infections, we have the immunomodulating 2 up, and these ones 2 little, 2 down. So, which is the concept that I would like to share with you? That has cytokine, which is the Bible of cytokines, in 2014 said, neither good nor bad in nature. I will tell you, for instance, interleukin-6 is responsible of low-grade chronic inflammation. But, poor guy, interleukin-6 is not always bad. It becomes bad when, instead of to be here, it is plus, plus, plus. The same, interleukin-10, that you will see, he is the interleukin with the strongest anti-inflammatory activity, so beautiful to have a medication based on interleukin-10, can become dramatically suppressing when plus, plus, plus. Only if they are in physiological concentration, picograms, femtograms, they work in the perfect way. That concentration is reproduced in the medications of low-dose medicine. So, if diseases, you already have seen that, are consequences of changed concentration in these molecules which lead our physiology to much or to little, is it possible to modulate the excess of a cytokine or to compensate the deficit of another cytokine? Because for us, health means to have these molecules in this range of concentration. For instance, in osteoporosis, we have PTH plus, 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 calcitonin minus, minus, minus. We have pH very low, acidosis. We have hormones, estrogens, minus, minus, minus. We have pro-inflammatory cytokines, especially interleukin-6 and TNF-alpha, plus, plus, plus. This is the picture of osteoporosis in terms of signaling molecules. So, once you will have this picture, now we have to understand it's possible to reduce the excess and to stimulate the deficit, because that's the goal of low-dose medicine therapies. Yes, it is possible. This is a very important slide from the studies published by Cook and Bettelli in 2006 and 2007. For the first time, this is really one of the key slides of today. For the first time, they described the cross-regulation between TH subset. Cross-regulation. What does it mean? It means that TH1 controls TH2 and vice versa in order to maintain the homeostasis of the immune system. How do they control themselves? TH1 produces a pattern of cytokines that you already have seen, but two cytokines are the most important ones. We can call them the basic regulatory cytokines. They are interleukin-12 and gamma interferon. Let's start knowing these ones. Why they are important? Interleukin-12 is able to make TH naive differentiating in TH1. In other terms, interleukin-12 upregulates TH1. Gamma interferon is able to down-regulate TH2. TH2 produce among all its interleukins, interleukin-4, which is able to upregulate TH2 and to down-regulate TH1. Through these interleukins, immune system control itself and keep itself in homeostasis. Now, just to involve you, if you had a patient with an allergy, atopic dermatitis, or allergic asthma, among these three interleukins, interleukin-12, gamma interferon, interleukin-4, which are the interleukins you would think in order to recover the balance that now is unbalanced, TH2 high, TH1 down? What do you have to do this? Using those cytokines. Which ones you think to use to recover the balance? Interferon gamma, very good, because with interferon gamma you put down TH2. And what do you have to do to put up TH1? No, interleukin-12. All right? So, this is the concept that Cook and Bettelli teach us. The concept of cross-regulation. Let's go to see if it's true that our immune system works this way. And we see one of the first paper about low-dose medicine published, very beautiful, pulmonary pharmacology and therapeutics. It is an animal model study, an animal model of allergic asthma. Okay, so when I say allergic asthma, if I make a scheme of the immune system, I mean TH1 very little, TH2 upregulated. Well, what did they do to study the effect of low dose of interleukin-12 and gamma interferon, as you correctly said. They start from a healthy mouse. Okay, lucky mouse, a healthy mouse. This is how do you say? Do you know this? That pupazzo? How do you say pupazzo in English? Okay, it's the name Topo Gigio in Italy. It was very famous in the 60s. Okay, okay. The immune system of the lucky mouse is this way. In order to study allergy, we need to unbalance. Okay, to do that, according to the international protocols, you have to inject intraperitoneally 1 milligram of egg albumin and 5 milligram of aluminium hydroxide. Injection day 1, after 7 days, after 13 days aerosol. In 18 days, the lucky mouse now is not more lucky, but is an allergic mouse. It means it's not more this way, it's this way. From this moment, they start treating the mouse with a combination of interleukin-12 plus interferon gamma, exactly according to the concept of cross-regulation. And these are only some of the data from this study. Okay, look, interleukin-4 in healthy mouse, interleukin-4 in allergic mouse, interleukin-5 in healthy mouse, interleukin-5 in allergic mouse. Why is very important in allergy, investigate especially interleukin-4 and 5. They are the markers of allergy. Because, so, Th2, they produce interleukin-5 that is important because it activates eosinophils. And you know how important eosinophils are in order to keep chronic, especially respiratory allergy. Interleukin-4, which is the real marker of allergy, is so important because it stimulates B lymphocytes to produce what? IgE. In not allergic people, IgE are only 2% of the IgE's profile. Since interleukin-4 is too much because Th2 are upregulated, B lymphocytes are stimulated too much to produce too much IgE, more than 2%. IgE, as you remember very well, sensitize mast cells. Second contact with the allergen, degranulation of histamine. This is the so-called allergic march. We have beautiful medications to act on the last step of the march, antihistaminics or corticosteroids. Do you remember the first slide? Low dose medicine is beautiful because allows you to overlap the therapies. Or if you are allergologist, you use the specific immunotherapy, the allergic vaccines. But the dream of every allergologist is to act on the original sin of the allergic patient, which is the imbalance between Th1 too little and Th2 too much. This is the real, we act on the cause and not only on the symptoms. That Hahnemann said, beautiful, we can work on the etiology of the allergy. So, the researchers did that, and they had these results. Interleukin, using the association of interleukin-12 and gamma interferon. So, you can think of that for your patient. Interleukin-4 in healthy mouse, interleukin-4 in allergic mouse. Interleukin-4, please look, after treatment with interleukin-12 and gamma interferon, allopathic concentration. 100 grams dose. Great results, look, from this to this. Which is the problem? The mouse died. It was not more allergic, yeah, but it was no more anything. Yeah, why? Because the big concentration is too strong and Th2 down, Th1 up, they died for any acute inflammatory disease. Instead, using physiological low dose, 1 femtogram dose, look the results. The same of the allopathic concentration without any side effect. And for the homeopaths, if you use 1 femtogram has the red column, not activated, fresh water doesn't work. Only the low dose activated is therapeutically effective. Beautiful, eh? And this is the first data. It was 2009 when we published this paper, and we, thanks to this paper, we understood a lot. For instance, we understood this mystery. This is something that for the researchers will be super interesting. When we, just 3 minutes, when we performed this study, we observed something that was crazy, and we were unable to explain it. 2 groups of mice. 1 group treated with allopathy, I mean allopathic concentration of interferon gamma and 12, and 1 group treated with low dose. Allopathy, we gave 10 to the minus 9, and in the BALF, bronchoalveolar lavage fluid, and in the blood, after 13 days, we detected 10 to the minus 12. That is absolutely logic. You give more and you find less because there is a clearance, a metabolism, and so on. To the other group, we gave 10 to the minus 15, so less concentrated. And after the same number of days, we found 10 to the minus 12. It is crazy. You give less and you find more. And we were really unable to understand that. But in the explanation of this mystery, which is not a mystery, there is the deep sense of this is a biological therapy. So Professor Rumio, who is the professor who performed this study, decided to mark the low-dose medication. And the first thing we observed was that what we found in the bronchoalveolar lavage fluid was not the interleukin 12 of the low-dose medication we provided. So he marked once again the medication low dose to see where it went to work, and he discovered that he stimulated the dendritic cells of the spleen. Dendritic cells of the spleen are programmed to produce interleukin 12. I mean, the interleukin 12 that we found in the BALF was not the medication, was the biological self-interleukin 12 produced by the mouse. Why he started producing its own self-interleukin 12? Because the message of the low-dose medication upregulated the transmembrane receptor of the dendritic cells of the spleen, and they started working again, producing interleukin 12. If you like homeopathy, Hahnemann, 260 years ago, spoke in terms of vital force. The homeopathic remedy stimulates the vital force of the body. For me, the vital force of the body is the capability of the dendritic cells of the spleen to produce interleukin 12. I mean, we change the languages, but the concept is always the same. It's a new concept of vital force. It's the vital force of the cell. And to stimulate the vital force of the cell, you don't have to scream. You have to whisper. You cells are like women. They are super strong, but you need to respect them. Otherwise, they say, I don't use the term, but you understand. Okay? Really, treat the cells like women. They are the most beautiful creatures of the world, of the universe. Since there is a prevalence of women, I'm okay. Look how beautiful is the preclinical research. You understand what you are giving to an organism. Okay. All right. Another, in this case, is a clinical trial. I'm very, very happy to have this opportunity to share with you these results. This is a long-term treatment with low-dose cytokines, interleukin-12, gamma interferon, plus adrenant medications. For instance, do you remember the adrenant medication for the matrix? That one is perfect in this case. In chronic childhood eczema, atopic dermatitis. This is a big clinical trial performed with one of the universities in Rome and the Italian Institute of Health. It is a double-blind, two-stage randomized control trial. So, the perfect design to understand if what you are giving, it is really working or not. Okay, I go directly if you agree to the results, okay? Just to know that inclusion criteria was that the kid had to have mild to medium, mild to moderate atopic dermatitis, okay? And they had to be included in the study, had a number of relapses the year before, at least 4. And to be enrolled, they had to be in acute phase of the disease. If they had more than 4 relapses per year, it means that corticosteroids were not working so much, so it was a big challenge for that. This is the trial design, double-blind, 2-stage, placebo control. I mean, after the first stage, those ones treated with the Virum were treated with the placebo and vice versa. This is absolutely important to exclude a placebo effect that always you have, especially in skin diseases. So, by a methodological point of view, I'm sure that you are appreciating serietà, the method, okay, the perfect method of investigation. These kids took for 2 months interleukin-12, gamma interferon, and, for instance, matrix. 2 months yes, 1 month stop. 2 yes, 1 stop. 2 yes, 1 stop. So it means that for 6 months they took the medications. But I recommend you this method. Instead of to give the medication for 9 months consecutively, it's better to do 2 months yes, 1 no. 2 yes, 1 no. 2 yes, 1 no. It is better in order not to make the cell to adapt itself to the stimulation you are giving. Okay, the end point was an improvement of the SCORAD, which is the score for atopic dermatitis, at least of 30%. Well, after 8 months treatment with low-dose medications, once again, interleukin-12, gamma interferon, and drenant, like matrix, the score had improved 54%. I mean, But even more important is the carryover effect that we observed. Carryover is the effect that you observe when you stop the treatment and the patient still improves. This is important by a biological point of view because it is the meaning is that since you are stimulating the cell to recover its biological function, once you have made the cell starting again, it works by itself. I mean, you don't have to give medications all life long. So I think that really these results are very, very, very interesting. Okay, these are the same I said to you, but so this can be a protocol for your young patients with atopic dermatitis. Please, mild to moderate atopic dermatitis in order to recover at least half of the physiological function of the skin. Okay, look that atopic dermatitis is the allergic asthma of the skin, as well as allergic asthma is the atopic dermatitis of the bronchus. So even in patients with not severe allergic asthma or in general respiratory disease, allergic respiratory diseases, this is the same protocol that you can consider.
Alessandro?
Yes?
In these studies, was a nutritional assessment made specifically and controlled for it, or?
In this study, no. They had, before to be enrolled, a washout from any other treatments, because in this case, we needed to observe only the effect of the low dose cytokines. If you ask me, and I will tell you absolutely, you have to add two more things. First of all, this is also from traditional Chinese medicine. Every time you treat a skin disease, drain the liver. So, do you remember, we have a specific low-dose multi-component medication with specific tropism for the liver. It's named liver. And interesting, the nutritional support, because always the dendritic cell, thank you for this question, it's very, very opportune. In literature, you find that kids with dysbiosis show a higher rate of atopic dermatitis. The same kids with respiratory recurrent infections treated consequently with antibiotics show a higher rate of atopic dermatitis. Why? The microbiota plays a crucial role. Do you remember the dendritic cell? Okay, dendritic cell was able to the toll-like receptor to bind lipopolysaccharides of gram-negative bacteria. And they present the antigen to CD4. CD4, when the dendritic cell presents antigen from gram-negative, but in general from bacteria, start producing interleukin 12. Interleukin 12 is the stronger activator of Th1. Do you need to stimulate Th1 in allergy? Yes. Not only CD4 produce interleukin 12, which activate also NK cells, which are the biggest producer of interferon gamma. Interleukin 12, interferon gamma, Th1 is exactly what we want to do to recover Well, if you destroy the microbiota or alterate the microbiota of these little kids, you don't have this mechanism. So, can be interesting to give these kids colostrum and noni. Can be important in this case, yes, to give probiotics, lactobacilla and bifidobacteria, in this case, yes, in order to recover the balance. And this is written in the consensus conference from the Italian Society of Pediatrics, published 2 or 3 years ago. They recognized the role played by probiotics in these kids. So, yes. So, I needed to be absolutely rigorous, telling the protocol of the clinical trial. But I would write here liver, and I would write here probiotics. So, absolutely yes. Well, so it's true that we can recover the balance of the immune system talking to the TH subsets using their language, which is the language of cytokines, according to the cross-regulation concept. Now, let's go speaking about inflammation. In this last, it's okay, I have 1 hour and a half, right? Okay, good. So, it's a big chapter, but it's really amazing. Okay, what do they have, these diseases in common?
Inflammation.
Absolutely, yes. And you know which is the most important, ... I mean, 90% of diseases are inflammatory diseases. And unfortunately, we don't have, apart beautiful medications for the acute, NSAIDs, corticosteroids, salicylates, biological drugs, monoclonal antibody, for instance, Humira, you know, in our country it's called infliximab, or biosimilar. We don't have anything for the chronic inflammation. So I want to especially speak about that.
Sorry, what about Montelukast? That never came in. Montelukast, it's an interleukin receptor inhibitor that
yeah.
would stop, would block the interleukin receptor and therefore
Yeah,
stop
it's still the same. They are, okay, with the monoclonal antibody, you can work directly against the interleukin. For instance, infliximab, Humira, block TNF-alpha. Or you can add also other medications like anakinra, which is an inhibitor of the receptor for interleukin-1. Okay, so you can block the ligand before the binding, or you can alterate the receptor so nothing will be bound. They are, in any case, classified as biological drugs, and they are monoclonal antibodies. The mechanism is a little different, but the effect is almost the same. Okay, and we will speak about the side effects of this type of medications also. So don't forget this cover of Time, The Secret Killer, that already in 2004, for the first, they published this issue making a link, establishing a link between inflammation and heart attack, cancer, Alzheimer's, and so on. So, since inflammation is a PNEI disorder, but especially an immune disorder, and since the concept of the balance is the best to investigate the immune system, once again, this is the picture of your patient with inflammation. Th1, Th17 upregulated, and the markers of inflammation, interleukin-1, 6, TNF-alpha, 17 upregulated, and unfortunately, we face a lack in TGF-beta, interleukin-10, interleukin-4. Since you already, excuse me, you want to take a picture?
it was literally when I just put
In the meantime,
you got it.
I take my jacket off. enzymes, you have the concept of cross-regulation. You remember? Every cytokine can be an opposing cytokine for another cytokine, an antagonistic cytokine. This is the table that we use to orient ourselves in the choice of cytokines. In the case of inflammation, that is what we are studying today, these with the red circle are the most important cytokines involved in inflammation, and with the blue circle, the opposing cytokines that, according to the concept of cross-regulation, are able to down-regulate, to push down the marker of inflammation. So we need to now learn how to use these blue ones that we have under the form of medications. If you like the picture of the scale, okay, these are the bad guys if overexpressed, and these are the solution to down-regulate these ones in order to recover the homeostasis. Look, that is almost a mechanical concept. So, let's go to study physiological inflammation, acute inflammation, and chronic inflammation. First of all, I want to start from the physiological inflammation. Look, that I'm not crazy calling it physiological inflammation, because I think that you too study the inflammation as the biological response of our body against a trigger, against a noxa, pathological noxa. In terms of cytokines, which lead inflammation, which is the picture? I'm speaking about physiological inflammation. That is that lethal inflammation, control inflammation that you have now. You have a lethal inflammation in your gut to ensure immunotolerance. You don't see any symptom, no calor, dolor, rubor, tumor, flu, or no signs of inflammation. Why? Because the inflammatory cytokines are, yes, overexpressed, but just a little, and in any case, inside of the homeostatic range. Do you see that I put this riquadro, okay, this box exactly there. Instead, the immunomodulating ones are okay. But since they are too much, you are borderline. You can have just little symptoms. Okay. Don't be scared, but this is absolutely important. The chronobiology of the pro-inflammatory cytokines when you have an inflammation. This is important to understand when to use anti-interleukin 1 or interleukin 10, for instance. Okay, look. In physiological conditions, the good inflammation, trigger of inflammation, you respond producing interleukin 1 beta. Not too much, not too little. But after 1 day, 2 days, interleukin 1 goes down. This is the characteristic of interleukin 1. The half-life of this cytokine is very short. But Mother Nature wants that we have an inflammation for more than 24 hours in order to counteract a virus, a bacteria. And after interleukin 1 beta, when interleukin 1 starts going down, we start producing interleukin 6. Interleukin 1 is the trigger of inflammation. Interleukin 6 is involved in the maintenance of inflammation. If the trigger of inflammation is not too strong, after 2-3 days, also interleukin 6 goes down. And why interleukin 6, which is involved in chronic inflammation, where interleukin 1 is involved in acute inflammation, they go down? Because the anti-inflammatory natural cytokines, interleukin 10 and TGF-beta, go up. If your immune system is able to work this way, you control very well your inflammatory processes. But if you have an insufficiency in the production of interleukin 10 and TGF-beta, or the triggers of inflammation are so strong that you produce storms of interleukin 6, these poor guys will be not enough to counteract interleukin 6 and interleukin 1. Do you understand this passage? This is the chronobiology. So, now, look what happens in acute inflammation. Please write in your mind, acute inflammation equal to interleukin 1 too much. Interleukin 1 is the marker of acute inflammation. That inflammation that you teach me lasts 2-3 days. In fact, the international guidelines recommend to use NSAIDs for no more than 3 days. Why? Because interleukin 1 after 3 days, my friend, goes down by itself. The problem is that they use NSAIDs for more than 3 days. And side effects are due to the long-term treatment with NSAIDs, not the short treatments. In terms of chronobiology, do you remember that in the physiological inflammation, interleukin 1 went up, but not too much up? Instead, in this case, this is the differential between physiology and pathology. Since now interleukin 1 is so overexpressed, you have fever, you have pain. This is the problem. So you need to counteract immediately interleukin 1 beta in the first hours from the onset of inflammation. We counteract interleukin 1 using a monoclonal antibody in low dose. Clinical question for you. Do you think that you have to use anti-interleukin 1 for a short time or for a long time? Short time, because after 3 days, interleukin 1 is not more overexpressed. So you are giving something for any reason, for no reason. In chronic inflammation, the marker of chronic inflammation is this guy. And believe me, in this case, low-dose medicine is really the most effective treatment in chronic inflammatory diseases. You can see that instead of to go down, interleukin 6 remains upregulated. And you see that it remains upregulated because interleukin 10, instead of to go this way, goes this way. So it will be easy to understand that if you want to counteract the excess of interleukin 6, have to use interleukin 10. If you have this simple concept, acute inflammation, interleukin 1, chronic inflammation, interleukin 6, we already can do very well. This is the picture of that condition that in medicine is called low-grade chronic systemic inflammation, which is 80% of the condition you observe in your patients. Because actually, also due to the lifespan, which is high, it's more common to observe chronic diseases than acute diseases. I like this slide. In fact, it's not mine, New England Journal of Medicine. This is dramatic. In 2011, New England said, look, that if you have a low-grade chronic inflammatory focus in a tissue or organ, the problem is not only of that tissue. I start my seminar this morning saying every disease is a systemic disease. Rheumatoid arthritis, but even osteoarthritis, it's not only a disease of the rheumatologist, the orthopedician. It's a disease of the internal medicine doctor. Why? Because if you don't treat this focus, interleukin-6 will spread out all over the body, affecting blood vessels, affecting the brain, affecting the bone, affecting the muscle sarcopenia, and so on. Low-grade chronic systemic inflammation. Do you think, you friends, do you think that you are or not in these conditions? Yes. I'm sorry for you. No, I'm sorry for me too. Because do you think that your gut mucosa is okay unless you are not stressed, you eat organic every day, you have some low-grade chronic inflammatory processes at that level? I have been operated twice to my right knee as a basketball player. Do you think that I don't have chronic inflammation in my joints? The problem is not of my knees. Is that maybe for this inflammation I will have Alzheimer's, or I will have an heart attack. I was super physical and now I have sarcopenia. I'm not this way, yeah, okay. Otherwise you say, okay, poor Alessandro. I'm quite good, but I'm trying to be a little dramatic now. So what I want to share with you is the concept that all of your patients, especially over 50, but also over 40, are in this condition. We need to do something. What can you do? Do you want to give them NSAIDs, cycles of NSAIDs? Doesn't make any sense. Maybe interleukin-10 will be the right approach for them. So, I want to put under the desk of the guilty interleukin-1, TNF-alpha, and interleukin-6. Okay? So, in this way, just to summarize, we will be studying acute inflammation, chronic inflammation, autoimmune inflammation. Let's start with interleukin-1. Why it is so important? Because interleukin-1 is crucial in the inflammatory process. In fact, interleukin-1, as you can see by the slide, is able to activate COX-2, prostaglandin E and D2, and nitric oxide. I mean, it is really the commander of the inflammation. That's the reason why it's so crucial. In conventional pharmacology, we have NSAIDs to downregulate COX-2, corticosteroids to act on prostaglandins, salicylates to act on nitric oxide. The dream of every practitioner would be to use in the same time NSAIDs, corticosteroids, and salicylates. Great results, but just a little side effect. Look, and if instead of to work at the end of the pathways, we would act on the origin, which is the upregulation of interleukin-1, it would be definitively smarter. Because if you will be able to block interleukin-1, you will be blocking the three pathways: COX-2, prostaglandins, nitric oxide. Do you appreciate this? It's great. It is a systemic, global management of acute inflammation, since acute inflammation is due to upregulation of interleukin-1. The medication that we use for that is anti-interleukin-1, which is a monoclonal antibody, low dose, able to block what? Cell, receptor, interleukin-1, anti-interleukin-1 is the antibody which block the binding of interleukin-1 with the receptor. So if interleukin-1 doesn't arrive to the cell, doesn't start the inflammatory process. We are not the only ones producing this monoclonal antibody. Even conventional pharmacology use monoclonal antibody against interleukin-1, but they use it in high concentration, which is the problem you observe when you use, for instance, anakinra, those, or infliximab, infliximab, rinolacept, canakinumab. This is something sophisticated but super interesting. To control interleukin-1, which is super effective, Mother Nature put in our body also the antagonist for the receptor of interleukin-1. Antagonist for the receptor. And the ratio between interleukin-1 and interleukin-1 receptor antagonist in physiological conditions is 5 to 3. You have 5 molecules of interleukin-1, 3 molecules of receptor antagonist. Why? Because a little interleukin-1 working in your body, you need it. Because interleukin-1, which is neither good nor bad, is important to stimulate the cell-mediated immune response. What happens when you use a high concentration of antibody for interleukin-1, that from 5 to 3, you pass to 0 to 3, because you destroy all the interleukin-1. For sure, your patient will not have fever or pain, but the first bacteria in this room will attack him. Not having interleukin-1, no good cell-mediated immune response, infection. Instead, using just a little of the antibody, you reestablish this homeostatic ratio. Remember, first of all, 100% safety. That is not a clinical safety, but also an immunological safety. When and how to use anti-interleukin-1? It's very important, the administration scheme. Please, start with 10 drops every 30 minutes for 2-3 hours. Then pass to 10 drops 3 times a day or 20 drops twice a day until the acute symptomatology completely disappears. We recommend anti-interleukin-1 in management, in pain management, especially benign pain, I mean not oncologic pain, musculoskeletal pain, tooth pain. I don't know, David, if you use, but it works really very well in the management of tooth pain. In little kids in Italy, pediatricians use anti-interleukin-1 instead of paracetamol for the treatment of fever. I mean, to control all the signs and symptoms of acute inflammation. Children under 6 years, half of the dosage of adults. Not of because any overdosage, but because they respond already to less drops. This is a beautiful medication. I mean, every time you think of paracetamol or NSAIDs, try with anti-interleukin-1 sometimes. All right. In your honor, I found this quote from Robert Herrick: "A spark neglected makes a mighty fire." I'm very poetic today. That means don't underevaluate the low-grade chronic inflammation, because you don't know, but you have that, and it is there, and is conquering new tissues. You need absolutely to, you need everybody to control it. The marker of chronic inflammation is interleukin-6. In that type of inflammatory diseases, interleukin-6 is dramatically upregulated. And even worse, it remains upregulated. You see, instead of to have the resolution of the inflammation, then it is still up. Whatever specialty you have, you are involved in what we are studying now. Because all the systems and organs are affected, can be affected by low-grade chronic inflammation. Cardiovascular system, the gut, just think IBDs, IBS, gluten sensitivity, celiac disease. Central nervous system, my God. Do you know which is the number of patients in Europe affected by Alzheimer's? 2017, 9 million. Okay? But the problem is that in 2035, we will have 18 million people with Alzheimer's. Is Alzheimer's an inflammatory disease? Yes. And that inflammation that is persisting destroy the communications between neurons, provoking tangles of microtubules. Why this prevalence in 2035? Because we are under attack of inflammation. Stress, food, drugs. So we need to do something. Immune system, cancer, autoimmune disease, metabolic system diseases. Just think of type 2 diabetes, insulin resistance, metabolic syndrome, vitiligo, psoriasis, rheumatoid arthritis, so on. So really, this is half of medicine, I mean. And these are the triggers of low-grade chronic inflammation. I wanted to be a little dramatic, but do you eat well? You try because you are good. Honestly, I teach this, but when I am at the airport of Denver, 3 o'clock in the night, and the only sandwich is a plastic sandwich, I eat that. Okay? I don't care. So, unfortunately, we don't eat well. It's not a problem, big problem in Europe, it will be, but in the States, GMO is a catastrophe. Overweight and obesity. In a couple of minutes, you will see what a fat cell contains, and you will be scared. Chronic stress, hypercortisolemia. Environmental pollutants. Okay, you stay in an island, but in northern Italy, pianura, we say on a plain, no wind, factories. Okay. drug abuse, incorrect lifestyle. This is beautiful. Maybe I already showed this paper, but I show again because it's nice. This is Brain, Behavior and Immunity, 2013. And they measure interleukin 6 that you learned is the marker of inflammation, chronic inflammation, according to an increasing negative emotions. For instance, anger or something like that. In two groups of people. A group of Americans from Manhattan and a group of Japanese able to meditate. Look at the difference. It's beautiful. I mean, stress induced the production of interleukin 6, which is the marker of inflammation. I mean, it doesn't make any sense to be upset with a friend, a colleague, because you increase interleukin 6. It doesn't care. You will be sick. That's the reason why peace and love is the best treatment. No, really. If you are not able to meditate or to be like Gandhi, you have to take interleukin 10. That is what I do because I'm not very able to meditate or to relax, being phosphoric. So I have to accept myself. I'm this way. Okay. It's nice. It's absolutely. Look that you are becoming elderly because of interleukin 6. Do you want? Oh, yes. Do you want to remain young? Okay. And look this. It's really dramatic. This is the prevalence of obesity during years in the 90s and in 2000, according to the age. You can see that between 50 and 70, we observe in Europe the highest prevalence of obesity. What is not more dramatic but tragic is blue 91, light blue 2000. Just in 10 years, look the increase of obesity. It's really dramatic. And why it is dramatic? Since we will die because of inflammation, this is what an adipocyte contains. They isolated about 650 different proteins, and adipocytes are bombs with interleukin 6, CRP, TNF-alpha, resistin. I mean, they are pro-inflammatory bombs. Bigger, more hypertrophic is an adipocyte, more interleukin 6 it will contain. Hypertrophy, hyperplasia. So it's absolutely crucial to keep under control this hypertrophy and hyperplasia, and in the meantime counteract interleukin 6, TNF-alpha with interleukin 10. Interesting is also the insulin resistance that is due to an excess of TNF-alpha, interleukin 6, leptin, and so on. Insulin resistance, we observe insulin resistance in PCOS, for instance, in metabolic syndrome. All of those are inflammatory diseases. So keep in mind if you think it's interesting. I'm sad to show you this. I am almost 57, so I am here. Until 50, even though you are a little hippie, your interleukin 6 is physiologically down, unless you have a little inflammation in the gut, a little inflammation in the joints, you are stressed, so maybe we have to put here. But even though you are the healthiest person in the world, you start producing more and more interleukin 6. But I would like to live until 110 years. Which is the problem? That since I have inflammation everywhere, even though I don't have any sign or symptoms, my lifespan will move towards the left. So, to keep under control interleukin-6, which means to manage the low-grade chronic inflammation, is for me the best secondary prevention in general medicine. So please consider this possibility. The problem is that no drugs in conventional classical pharmacology are designed for that. And if you use chronically NSAIDs or other drugs, you have side effects. I don't want, I had thousands of papers about the side effects of NSAIDs that are wonderful medications for 3 days. It's not me saying that, international guidelines. This is cardiovascular risk of non-steroidal anti-inflammatory drugs, an under-recognized public health issue. NSAIDs and the failing heart, NSAIDs and cardiovascular risk. And these are papers, very important journals. I mean, BMJ, once again. So, do we have an alternative? Yes, it's interleukin-10. I'm saying because I hope you will appreciate and you will try with your patients interleukin-10. This is another slide. These are the under trial. Diclofenac, ibuprofen, rofecoxib, and celecoxib. These are the most dangerous in this moment, according US Food and Drug Administration and EMEA in Europe. This is interesting. Look, in the repair mechanism of a tendon, if you don't do anything, you start producing preprocollagen. If you give your patient NSAIDs, look, you block the production of preprocollagen. That means you block the repair phase of inflammation. So we need to take under control the inflammatory symptomatology without blocking the repair phase. What can we do? Okay, officially, administration of interleukin-10. This is the new medication in the clinical environment to take under control this type of diseases. A lot of publications about the use of interleukin-10, they don't know that already exists interleukin-10 under the form of a medication which is safe because low dose, and it is interleukin-10 low dose. According to what I told you till now, the administration scheme for interleukin-10 low dose, which is the medication for chronic inflammatory disease, will be 10 drops every 30 minutes for 2-3 hours, or 20 drops twice a day for 2, 3, 4 months. Absolutely, because interleukin-6 remains upregulated for a very long time. It's not like interleukin-1 that by itself after 3 days goes down. Okay, so it's important to use this scheme. Look that we have learned a lot of different medications today. Anti-interleukin-1, interleukin-10, interleukin-12 and gamma interferon in allergies. We learned the medication to drain the matrix. We learned how to take care of our gut, colostrum and noni. So I'm really very, very satisfied. A lot of papers on interleukin-10 low dose, look that if you want these papers, the full text, you have just to ask our partner, and I will send you everything, also my slides. They are not my slides, are your slides. In Italy, I want to share with you this experience in our country, especially for general practitioners and cardiologists. Professor Massimo Fioranelli, who is a cardiologist in Rome, the head of the department, of the heart department at Mater Dei Hospital in Rome, did this clinical trial. Patients with stable coronary disease. I mean, they are those patients with a plaque which is stable because under treatment with acetyl salicylic acid and clopidogrel plus statin. You must do that, otherwise the plaque. But according to the international literature, these patients have a prevalence of heart attack that is 16%. The question is why, if the plaque is stable? Because if you go inside of the plaque, looking at the plaque, you will find platelets, macrophages, and especially adipocytes. What do adipocytes contain? Interleukin-6, CRP, TNF-alpha that released from the plaque attack the endothelium, inflaming it, 16% of heart attack. Professor Fioranelli split the patients in two groups. One group treated only with the gold standard therapy, anti-aggregant, acetyl salicylic acid, and statin. Follow-up 3 years, confirmed 16%. Another group treated with acetyl salicylic acid, statins, plus 20 drops daily of interleukin-10. Follow up the same 3 every day, all life long. Every day, 20 drops. Prevalence of heart attack, 5.6%. 16 to 5.6. For those of you who are familiar with statistics, the P of this study was under 0.001%. To be significant, as you know very well, it must be 0.05. Lower it is, more significant it is. So it is absolutely highly significant. This is a beautiful study because it is the expression of overlapping therapy. I mean, you must be crazy not to use acetyl salicylic acid and statin. But what can you do? You give your patients NSAIDs. Come on, have you seen what they say? NSAIDs and they fail our heart. So that can be interesting. You are not avoiding any medications, so perfect. This is a way to use this low-dose pharmacology. Well, autoimmune diseases. On the desk of guilties, TNF-alpha and interleukin-17. Those are really bastard. Because not only they are very, very inflammatory, but they are also able to destroy the tissue. For instance, in diabetes type 1, TNF-alpha interleukin-17 destroy the beta cells of Langerhans islets. In rheumatoid arthritis, they destroy the cartilage, synovia, and bones. So really, they are very, very dangerous. What can we do to take under control Th17, which are overexpress every time you are facing an autoimmune disease, you already know that. Interleukin 4. Interleukin 4 is the cytokine that always you have to think of when you face a patient with an autoimmune disease. Okay, interleukin 4, control of Th1, Th2 switch. Even in this case, it's always the same. The posology, 20 drops twice a day. And other you want to take a picture? Please, no problem. But anyway, remember, in acute, 10 drops every 30 minutes for 2-3 hours, not for interleukin 4. In chronic, 20 drops twice a day for 2, 3, 4 months. And you can repeat the cycles until symptomatology completely disappears. All right? Take note also of TGF-beta, which is the growth factor involved in the inflammatory process, in the resolution phase and restitutio ad integrum of the tissue, because TGF-beta is able to stimulate the deposition of collagen in the matrix. So it's the most important low-dose medication in wound healing. For instance, your patients with diabetic ulcers, or ulcers because they stay in the bed, or in aesthetic medicine, they use with success TGF-beta in order to fill the wrinkles. Not injecting, but stimulating the deposition of collagen. In aesthetic medicine, the combination matrix, to clean the matrix, TGF-beta, it's really very, very interesting. So, this is the final scheme I want to show you to wrap up what we have done together and said. Anti-interleukin 1, decrease of acute inflammation. Interleukin 10, decrease of chronic inflammation. Interleukin 4, control of autoimmune disease trigger. TGF-beta, resolution phase, restitutio ad integrum, wound healing. With these 4 medications, and especially the first 2 ones, you will do a great job in this kind of diseases. No side effects, not overload, effectiveness. If you like to think in terms of multi-component medications, also take a note about this combination for inflammation, where you have both anti-interleukin 1, interleukin 10, TGF-beta. You have also beta endorphin, and you have melatonin, together with the typical homeopathic remedies that normally the homeopaths use to take under control acute and chronic inflammation. This is beautiful. This is a very easy to use, a drug very easy to use, that you can use in acute, in chronic, changing the administration. In acute, 10 drops every 30 minutes, in chronic, 20 drops twice a day for a very long time. All right. Questions about this before showing some studies on these pathologies? Okay.
What was the name of the previous one, the combination?
Phlegm. Inflammation, phlegm. I show you. I have my little bag of first rescues, where I have always phlegm, cytomix, because and digest, because when you are somewhere and you are alone in an hotel and something happens, when you have an anti-inflammatory drug, immunostimulating, something in winter also for the flu, and something to digest, okay.
You're good to go.
Yes. Yeah. Okay, so the paradigm shift, we started from that, no? I want to spend these last 30 minutes showing some data, and I want to start about the results in Alzheimer's, okay? Which is really an increasing pathology. Actually, do you know any treatment for Alzheimer's apart, okay, something palliative? It's a tragedy for a family. It's very related to also to stress in general, inflammation, hypercortisolemia. Take under control stress, my friends, because stress affects all the tissues in our body. And our generation, unfortunately, is really under stress. So we need absolutely to know that. Please remember that I start from this axis and I will arrive to the Alzheimer's. HPA axis, hypothalamus, pituitary gland, adrenals. Stress, this is central nervous system. Stress, releasing hormones, stimulate pituitary gland to produce ACTH. ACTH stimulate adrenal to produce cortisol. Hypercortisolemia is able to affect both the upper part of PNEI axis, central nervous system, and the lower part, the immune system. Everybody experiences under stress upper susceptibility to viral infections, because cortisol downregulates Th1. So you have less cell-mediated immune response. But look what happened to the upper part. Under stress, hypercortisolemia, activation of the long circuit of retroactive inhibition, and you block the receptor at the level of hypothalamus. That's the burnout syndrome. If cortisol remains upregulated for a long time, you are not more able to start the stress axis. We need a little stress. It's called eustress. The problem is the distress. But if you never start stress, if a lion is behind you, you don't start running. Instead, you need that. Okay, so look at the upper part of the PNEI, what hypercortisolemia does. You already know. ACTH, cortisol upregulated, and hypercortisolemia downregulates 5-hydroxytryptophan, which is the precursor of serotonin. Now we understand the relationship between stress and depression. Even more important, my friend, is the triangle between stress, inflammation, depression. Look at the following slide, which is a little complicated but beautiful. Okay, follow the list, the point. HPA activation. Look at the left side now. Hypercortisolemia. Cortisol is a killer for neurotrophic factors. So you don't have more the possibility to have neuronal repair, apoptosis, especially at the level of hippocampus, memory and cognitive deficit, dementia, Alzheimer's also. Even more important is what happens under stress on the right part of the slide. Chronic stress activates low-grade inflammation. When I say low-grade inflammation, give me the satisfaction to answer in the right way. Which is the interleukins upregulated in that case? Great satisfaction. Thank you very much. I'm very happy of my friends. Okay, good. Interleukin 6, between the hundreds of things that it does something that is not, Alessandro is saying something sophisticated. It's crucial for your patients with depression. Interleukin 6 is able, that you know very well what it does, okay, is able to activate two enzymes named IDO and TDO. IDO means indolamine deoxygenases, TDO, tryptophan deoxygenases. What you need to remember is that these two enzymes make the pathway tryptophan, 5-hydroxytryptophan, serotonin, shifting in the pathway of kynurenine. Kynurenine is a fake serotonin, but with a very high affinity for serotonin receptors. What does it mean? That if you are under stress, you are inflamed, you produce interleukin 6, you produce IDO, you produce kynurenine. Kynurenine occupies your receptor for serotonin, and when your serotonin arrives, receptors are closed and you are depressed. Not only kynurenine does this, but it is also very neurotoxic. This is something really very updated, because it has been published in 2016 in Neurobiology of Stress, and this is a study from the neuroscientist of the Mount Sinai in New York. And look the title, Integrating Interleukin 6 into Depression Diagnosis and Treatment. Why I spend 1 hour speaking about interleukin 6? Because really here today in Dublin, I was saying Berlin, in Dublin, I have to be in Berlin next week, excuse me. In Dublin we are doing something that is apparently the future, but it is the present, because you are scientists, you are reading continuously these papers. So, interleukin 6 related with depression, absolutely yes. But you know what to do to counteract interleukin 6. Give me the second big satisfaction of today. Interleukin 10, great. You know why it's important for me? Because you are inside of the mechanic of low-dose medicine. It means that you already are low-dose medicine doctors. Okay, so can be this an interesting approach. Interleukin 10. Why matrix? Because those patients arrive to you that they have used SSRI for 10 years, other type of conventional drugs. So the matrix, my God. Why is important? Colostro and noni. Gut-brain axis. Gut-brain axis. If you don't take care of the gut, the mood will be not so good. And look that when you are stressed, your bowel doesn't work. When your bowel doesn't work, your mind and your mood are not good. 90% of serotonin is produced by the enterochromaffin cells in the stomach, in the gut. Only 10% of serotonin, if I'm not wrong, is produced by the cell of the nucleus of bulbo and raphe in the central nervous system. So, if if you don't give a caress to the gut mucosa, I don't know. That's the reason why when you are in love, you don't tell your heart beating fast, but you feel the butterfly in the stomach. Yeah, gut-brain axis. In my life, it happened too often. In fact, I feel some best. But this is now no more butterflies. Now, no, just for my wife. So, why? Because depression is systemic, and even more unbelievable is an inflammatory disease. It's interesting also this complex, this multi-component for mood disorders. Look, it contains tryptophan, hydroxytryptophan, and serotonin. For instance, it works wonderfully in, I don't know if I say it well in English, binge eating disorder with craving for carbohydrates. Yeah, because some papers show that these people eat continuously sugar and carbohydrates to increase insulin, not only because carrier of sugar, but also because insulin is carrier for tryptophan at the level of neurons. So, if you give tryptophan instead of serotonin, you follow a physiological pathway. For all the homeopaths, please look, Sepia and Ignatia. Okay? Interesting is also the presence of lachesis, which is an homeopathic remedy obtained by the poison of a snake. It is very interesting in order to stabilize the neurovegetative tone. So, mood disorders in menopause, hot flashes, beautiful multi-component low-dose medication. Question for you. Interleukin-6 upregulated, responsible of pain, fatigue, depression. When do you observe pain, fatigue, and depression? In which disease is typical? Is fibromyalgia. Great. Fibromyalgia is the paradigm of low-grade chronic systemic inflammation disease due to upregulation of interleukin-6. Just consider that until 10 years ago, more or less, women, because the majority are women, with fibromyalgia were considered hysteric. In fact, therapy antidepressant. They were not hysteric. They were inflamed. And a very good professor in Italy, a neuroscientist in Turin, thanks to some image technique, brain mapping, identify in these patients always some areas, always the same, of perivasal inflammation. Poor women, they are inflamed. And if you go here, you will find high concentration of interleukin-6 and another protein, which is named VEGF, Vasal Endothelial Growth Factor. That is good if you have just a little, in order to stimulate the vascularization. But if upregulated, it is 1,000 times stronger as inflammatory molecule than histamine. So it's really painful for these women. This can be an interesting approach for fibromyalgia. Absolutely interleukin-10, not less than for 3 months. Absolutely important matrix, because the trigger points are area of connective tissue. Very interesting is the multi-component for inflammation. When you need to control the flare of pain, because that multi-component contains beta endorphin, an anti-interleukin 1, and sometimes, you know, there is this sleep disorder, so it's interesting also the multi-component for sleep disorders that contains serotonin, melatonin, pineal gland, and some typical plants for in phytotherapy for mood disorders.
What is that called? What is the name of that one?
Sleep. Sleep. It doesn't work like 20 drops of Valium. It's much more gentle. It works, look, according to my experience, after 1 week you are taking this multi-component, you see the results. So it's important to tell the patient it's not like 20 drops of Valium.
What is the dosage?
20 drops twice a day, plus 20 drops half an hour, 1 hour before going to the bed. You can use very well in overlapping with benzodiazepines in order to disassuefate. Okay. How do you say?
To wean off.
To wean off. Okay.
Yeah.
To wean off the benzodiazepine administration. In that case, it's better to reduce the drops of Valium than the times you take Valium, because there is a psychological dependency from the attitude. All right, and last but not least, David, sorry, maybe I stole 20 minutes to your lecture. Stress, interleukin 6, and neurodegenerative diseases. We need to be aware about this. People living with dementia around the world. Okay, we are in US. Sorry, I told you in 2035, in 2050, from 10 million to 18 million people with Alzheimer's. In the United States, look, in the United States, 9 million, 30 million. They are killing themselves. My wife, she's American, she said, in the United States, they don't need, no, they said, ISIS in the United States can also not go there. We are killing ourselves. we are killing by ourselves, especially the food and also the lifestyle that is really very stressing. What is not completely understood is this prevalence that is even worse than in the United States in Asia. Some scientists relate this prevalence to the fact that in China, especially 1,400,000,000 people, they are changing their lifestyle so quickly from soy to McDonald's. So maybe it's this. So anyway, I think it's a world emergency. It's a world emergency. Is Alzheimer's an inflammatory disease? Completely. This is the panel of cytokines involved in Alzheimer's. TNF-alpha, 6, and 1, in this order exactly. So it's typical inflammatory disease, no question, no question. It's interesting to see what happened. It's really interesting. When you are okay, you don't have any inflammation, tau protein in the brain stabilize microtubules in the extracellular matrix. If you have an upregulation of interleukin 6, for all the reasons you know, you activate a kinases called tau protein kinases, which transform tau protein in phosphorylated tau protein. This little P group change the function of tau protein. No more stabilizing the microtubules, but disorganizing the microtubules. And it induced the formation of tangles of tau protein. which not allow more communication between neurons. I mean, we have thought for many years that the problem was the formation of amyloid. Maybe it's not amyloid, it's tangles of tau protein, of microtubules, because of the tau protein phosphorylated. This is another dramatic paper, JAMA, Journal of American Medical Association, 2013. Proton pump inhibitors and histamine 2 receptor antagonists use and vitamin B deficiency. Here they say that using for more than 2 years proton pump or H2 inhibitors is related with a dramatic increase in neurodegenerative diseases. Why? Because blocking the parietal cell, you don't block only the production of chlorhydric acid, but parietal cell also produce intrinsic factor, and intrinsic factor is crucial for the absorption of B12. So no B12, neurodegenerative diseases. So maybe that increase in the prevalence of Alzheimer's is due also to some incorrect use of some drugs. And I'm sure that you will love these references. Alzheimer's disease and gut microbiota modifications, pharmacological research. The microbiome and disease, reviewing the links between oral microbiome, aging, and Alzheimer's disease. Scientific reports, microbiota modulation counteracts Alzheimer's disease progression. My God, if you are right when you said, take a look at the microbiota. A disruption in the homeostasis of the microbiota provoke an inflammation in the gut mucosa, the disruption of junctional system, chronic inflammation, Alzheimer's. We already have seen that slide now. It's absolutely clear. You already know what to do to counteract this mechanism. Colostro and noni. Please remember that. And even more in these patients, consider our multi-component medication for elderly people, so the multi-component for geriatrics. Look how many components it contains. It contains, look, IGF-1, melatonin, and ACTH in low dose. Melatonin is an immune system strengthening. Insulin growth factor, inhibition of apoptosis, including neurons. ACTH is involved in capability to learn, orientation, and memory. It contains TRH, oxytocin, and LH-releasing hormone. Oxytocin, social behavior. Elderly people are every day more closing themselves. Oxytocin is the neurohormone of social behavior. TRH, so important in cholinergic transmission. LH-RH, luteinizing hormone, releasing hormone, interaction between neuroendocrine and immune system. In elderly people, all these signaling molecules are dramatically low. And the core of this multi-component, neurotrophin 3, neurotrophin 4, and I hope that in these last 10 minutes of my speech, you will fall in love with BDNF. BDNF, first, is the most studied nervous growth factor. It is the most important against Alzheimer's. It is one of the most important growth factors in autistic spectrum disorders. It is the growth factor able to keep plastic the brain, actually. Look, it is crucial for learning and memory, synaptic plasticity, because you can also have a plasticity of the brain, but what is important is the synaptic plasticity. Axonal germination, neuronal proliferation and differentiation. For instance, BDNF is able to stimulate the proliferation of astrocytes. Astrocytes are the only nervous cell able to proliferate. BDNF has a direct correlation between its production and human brain aging. It means that more we become elderly, less BDNF have. BDNF is very sensitive to oxidative stress, reactive oxygen species, which is by itself cause of aging damages. Reactive oxygen species are related to inflammation, so it's always that terrible vicious cycle. High concentrations of BDNF are linked to higher cognitive capabilities. Tomorrow I start taking it because I am in the age. It is supposed that BDNF plays a protective role against Alzheimer's and other forms of dementia. 2016, this paper. So we perform a trial. Now I show you. Interesting. Interesting is that the BDNF is produced more or less by every tissue of our body. Interesting is that it is produced, for instance, by muscles. That's the reason why Alzheimer patients who do some exercise, they stay better. It's obviously the brain is the bigger producer. So this is, and with this I will finish. This is the study with the University of Novara, which is a city close to Turin in Italy, Department of Human Physiology, and it is both an in vitro experiment on neurons and cortical neurons and astrocytes and animal, in order to see many things, and especially the reactive oxygen species reduction, cell viability, and the capability of BDNF to overcome the biological barriers, especially the blood-brain barrier. This is a great study. It is in press. So first, reactive oxygen species. In black, the placebo. In red, the BDNF allopathic medication. In blue, BDNF low dose. First, BDNF low dose is more effective than the allopathic concentration of BDNF. We are still used to think in terms of cure dose response. More drug you give, more effect you have. Not for these molecules. I mean, it's true for antibiotics, it's true for NSAIDs, it's not true for cytokines, hormones, neuropeptides, growth factors. This is in the oxidative stress in cortical neuronal cells in astrocytes. Blue, low dose, red, high dose. Always best performance from low dose. Super important. Guna is the name of the product they use. BDNF overcomes enterohepatic circle and reaches the cerebral tissue. In this case, you see that arrive to the brain more molecules of BDNF if you give them in low dose than if you give them in big dosage. It's almost the opposite. More you give, more arrive. Less you give, more arrive. Both in cortical neuronal cells and astrocytes. And here you can see the viability of cortical neuronal cells and astrocytes. Look that there is a big difference. Proliferation of astrocytes. Don't forget that astrocytes are the only ones able to proliferate in our brain. And you can see that the result is much better with low dose BDNF. Low dose protect neurons better than high dosage. This is a big study. This is a big study. It's true that it is an animal model, but mice reproduce what happens in humans. Okay, so I think that a possible interesting approach for cognitive function failure, even Alzheimer's, is, first of all, take under control inflammation. Geriatrics or BDNF. Geriatrics is the name we have given to this multi-component medication. Fem and male, which are medications to reestablish a good balance in the entire PNEI axis, but it is accessory. Very important is colostrum and non-colostrum. I think that really with this scheme will be interesting to observe the results. I'm quite sure that very possibly what we will observe will be a slowdown in the progression of the disease, which is already great for these patients, especially in the first phases of the disease. But in general, these medications are more effective as soon as your patient will be under treatment. They work so well in the early stages, but also in osteoarthritis, also in rheumatoid arthritis. The early stages are the moments to start the therapy. Okay, it is exactly 4:30. It's time now for me to shut up and to give the words and the stage to my friend, very good friend, David. I don't know if we want to take 5 minutes break, and then David will speak about his experience.